ask Aaron Boster to come online next. You're looking awesome. The hat's a little big for you, but it's okay. It's all part of your attitude. I got it. All right. Now, for those that don't know Dr. Boster, first off, I'm glad to say, and I'm proud to say, that he and I have been friends for years. And so we have Dr. Boster on many of our programs. This is 2 years in a row, along with Gretchen, 2 years in a row, doing the symposium with us, and that's just fabulous. I remember when Dr. Boster opened up his clinic. Okay, it was right at the beginning of COVID. I mean, he was building his offices in January. He was getting ready to open on March 1st, and the world shut down. Okay, and what a way for a guy to start a new business with the world shutting down all around you. All right, It was tough, and that's why we also did a thing on telehealth. And Dr. Boster right now, in place of Dr. Hughes, is going to be speaking about telehealth. He's also going to be speaking about several other things. But at the beginning, and I don't know if he's going to mention it, but he and I did an actual patient-doctor telehealth call so we could wake up the community and let them know how simple things are. So I'm going to not speak and not gibber anymore. I'm going to let Dr. Boster take over. I'll be back on in 35 minutes. We'll start the Q&A at that time. Please remember, everybody, if you've got questions, type it in online. We'll try to get them all answered, okay? Thank you. Bye-bye.
Thank you, Stewart. Howdy, and thanks for learning about MS with me, Aaron Boster. I want to give a heartfelt thank you to Stuart Schlossman, a true friend of mine, and the entire MS Views and News crew for inviting me back so that I could try to up your game and bring you some MS education today. This gala is something that I look forward to every year, and it's really a fantastic opportunity to connect. So thank you very, very much. As Stewart shared with you, today's lecture, entitled Access to MS Care in Underserved Communities in the Telehealth Era, was intended originally to be presented by none other than a close friend and outstanding MS neurologist, Dr. Mary Hughes. Much to my chagrin, Dr. Hughes is unable to make it, and I am going to jump in and try to do the best I can to honor her presentation. Now, today we're going to be talking about a lot of really intense topics. We're going to be talking about disparities in care and access to care and inequalities that we need to correct. I want to set the stage by sharing with you that I did my formal MS training with Dr. Omar Khan and Bob Lissack, two great men who trained me at Wayne State University. Now, why is that relevant to this lecture? Because Wayne State University is in Detroit, Michigan, one of the largest communities of African Americans in the United States, and the second or third largest African American MS clinic. We had a tremendous number of families, African American families, and also families from the Middle East that we cared for. And so my formal training in MS was steeped in an understanding of ethnic minorities. Now, there are a couple key takeaways that I want to share with you from that experience working in Detroit, largely with families who are African American and Middle Eastern. Number one, people impacted by MS who are African American have a more aggressive disease course than Caucasians. Now, I'm talking about groups of people, not individual humans, but it was very, very clear to us that African Americans with MS had a much more fast progression of disease. Now, in fact, we published some research when I was a fellow. I looked at all of the children that we were caring for at the MS Center. We had a bunch. And I looked at all the kids that were African American and all the kids that were Caucasian. And I compared the relapse rate, the disability progression, the MRI changes. And as you might expect, unfortunately, African American children had much more aggressive disease. And so we were able to publish and contribute to the understanding of the disparity in the differences in the way that people with MS have disease course based on ethnicity. Now, the second thing that I learned as it relates to this topic is that there is a importance of the family in providing care. Now, that's not true just to one ethnic group. It's true amongst all human beings, but I learned this in the setting of caring for African American families, and I want to explain using an example. So the way the clinic worked back in my fellowship is I would go in the room and I would collect all the information and do the exams, and then I would go tell my mentor and I would present the case to him and we would discuss it, and then he would come in the room and do his magic. And I went into a room and there was a very nice young lady maybe early 20s with her grandmother. They were African American, and she wouldn't make eye contact with me. She wouldn't look at me. She would barely answer my questions. She was proverbially sitting there on her phone, and I couldn't connect. I couldn't take a history, and I didn't know what to do. I was befuddled. So I excused myself, and I went to my mentor, and with my head hanging down, I said, Omar, I can't get this patient to talk to me. And he said, well, describe the situation. So I did. And he paused, and he said, here's what I want you to do. Go back in the room, sit down, and talk to grandma. Talk to the matriarch of the family and explain to her what your goals are and what you're trying to accomplish. And I kind of looked at him funny, and he goes, go on. So I did. I went back to clinic, and I sat down and said, sorry for the interruption. And I moved my chair in front of grandma, and I started to talk to grandma. And I was explaining to her the goals of clinic and what we were trying to accomplish. And partway through, she said, excuse me, doctor. And she turned to her granddaughter, and she said, honey, you will listen to this nice man. He will help you. I get tearful when I share that story with you, because that young lady changed. And she, because her grandmother, the matriarch of the family, okayed my relationship, she became an outstanding participant in her own care. Now, that was a very emotional experience for me, because it was a learning for me of connecting with a human being in a very meaningful way. And this is something which has stuck with me. And it was a lesson that I learned in working with ethnic minorities in MS. Now, the third thing that I took away from my fellowship is something sad. And it is a cultural mistrust amongst many ethnic minorities, particularly African Americans, with doctors, and specifically with medical research. I'm talking about a cultural travesty that we have to call out. The Tuskegee Experiments around the 60s, where white scientists went out into the plantation areas where African American gentlemen were working in agriculture and tested them for syphilis. And some of the gentlemen had syphilis. And the scientists chose not to tell them. They hid the diagnosis of syphilis. They did not treat them with penicillin, and they watched them. Each year they came back and saw them progress. And that is absolutely abhorrent and disgusting and a travesty. Now, there are institutions within the United States that have been created to prevent that from ever occurring again. Any research that we participate in is required to go through a rigorous institutional review board, an ethical committee, to ensure that nothing like that ever happens. And yet, it's not that long ago. The cultural ramifications persist, and we are deserving of some resistance and some distrust. And it's my opinion that it is incumbent upon doctors and researchers like myself to help change that feeling. I think it's really, really important. And I'm going to come back to that in a few short minutes. Now, let's move forward. And with that background, I want to go over some facts. All right. So what are some facts that we know about MS and ethnic diversity and differences? Well, number one, we know that MS is not really a disease of young white women the way that we thought it was even 20 years ago. MS affects all age groups. And yes, the average age of onset is 30, but it's a bell curve. I've diagnosed folks that are 6, and I've diagnosed folks that are 86, but that's rare. And the majority of folks are 20 to 40. But they're not mostly white. When I was in training, I was taught that MS is a white disease, and rarely you can see ethnic minorities. And the reason we saw so many in Detroit was because there was a bunch of folks in Detroit of that ethnic group. Not the case. As we have updated our understanding of the epidemiology of MS, we know, first of all, that we misjudged the number. We thought there was only 400,000. There's almost 1 million people in the United States with MS. And it is not less common amongst ethnic minorities the way that we used to think. It is more severe. And so those are facts. What else do we know? We know that despite the differences in different ethnic groups, they have not been studied adequately. And I hate to share this, but the majority of MS clinical trials are devoid of African Americans. There are clinical trials with 1,000 human beings with MS where we're studying drug A versus drug B. No one is Black. And given that there are differences, that's a really big issue, because what that means is we might not know whether a given drug works in that ethnic group. And that's a big, big problem. And it's compounded by the fact that there is a complete paucity of African American and ethnic minority participation in MS research today, 2021. I am happy to share with you that this is a major, major focus of research. Even the collective MS pharma organizations, the manufacturers, are clamoring to ensure inclusivity and trying really hard to facilitate getting ethnic minorities into MS research. And it's so very, very important. Now, I want to present to you a path where we can make it better, where the folks listening today can make it better, where clinicians can improve this situation. And I'll present you with three things. Thing number one is education. It is critically important that we educate communities. I've had many, many African-American patients tell me, I was told I couldn't get MS because I'm Black. And that's false. And so there needs to be an education. And I want to call out Stewart and MS Views and News because they have done something which is not adequately recognized. They have targeted small, underserved communities throughout the United States. They have gone out in a targeted fashion, embedded education in these small communities where MS Views and News will literally travel to a small town and do a program, or they will do it live and remotely. And it's really a wonderful, wonderful effort to help bring cutting edge MS education, not just to the big cities, but to communities that really, really need to hear it. And so I want to say thank you to MS Views and News in your efforts at trying to help bring education and bring an opportunity for people in underserved communities to up their MS game. And we need to continue that effort. So that's the first thing. The second thing is, I think that we need to have, we being MS clinicians, we need to have very, very open and very honest discussions with families as it relates to clinical care and in specific research. And so I would like to touch on that for a few minutes. At the Boster Center for MS, I'm very, very delighted that we have several clinical trials and registries that we're currently offering. And this past month, I had a wonderful but intense, unique experience with two families. This was separate. And in both situations, I was making an MS diagnosis in a woman who was African-American, and we needed to talk about disease-modifying therapies. And so, as per my usual, I wrote up on the board several medications that would be appropriate for her, including the word clinical trial. And I said to her, listen, I want to talk to you about some medicines. And if you look on the board, I wrote the word clinical trial. And I would like to discuss with you the possibility of some clinical trials. But before, I want to share with you why I want to ask you about it. And she said, okay. And her husband kind of perked up. And I explained to them what I just talked to you about. I talked about Tuskegee, and I talked about how we were trying to correct a wrong. And I talked about how there were differences amongst African Americans and Caucasians, and yet we weren't studying African Americans in trials adequately. I talked about how there is a paucity of African American participation in research, and how the number one reason was that doctors weren't asking African Americans if they wanted to participate. And so I wanted to correct that wrong. And I told them, we don't have to even talk about the research. I'm just delighted that you'll let me bring it up because I feel like it's really important. And they were interested, and we talked about it. And they took the consent form home and they read through it. And they talked to their loved ones about it. And they talked to some of their community leaders about it. And they came back to clinic. And together we made a group decision to participate in clinical trials research. And I am so happy to be able to share that. And I am so honored that this family was willing to trust me in this journey that we're going to take together. And we need to do that a lot more often. Now, I also want to bring up a type of research which is really, really something that we don't use enough and is extremely valuable as it relates to understanding the differences amongst ethnic groups in various communities. I'm talking about registries. So not every person with MS is able or interested in participating in an intense clinical trial where we're experimenting with drug A or drug B. That's just not in the cards for everyone. Some people have comorbid conditions that disqualify them, or they live too far away, or their work schedule is such. But registries are different. I'm very, very happy that at the Boster Center for MS, we have two really cool registries where any patient with MS can participate. And we look at their clinical data. We remove all their names and stuff, so you don't know who it is, but we upload it to create a repository of real human beings with MS. And the more ethnic minorities that we can contribute to this registry, the better it is that we can understand those differences and how to beat them. Now, the third path to improving access to underserved communities is through telehealth. And I am now going to shift our attention to a discussion on telehealth with a focus on how we can use it to improve access to all human beings with all chronic conditions. But to do that, I have to stand up and flip this page. I feel like Paul Harvey, and now I'm going to go on to the rest of the story. So if there is a silver lining to this global viral pandemic, which has been an unprecedented travesty in all of our lives, it might be the adoption of telehealth, quite honestly. There may be, at least from a medical standpoint, a silver lining in that telehealth was introduced at a global level right away. Now, if I reflect back pre-COVID, my experiences with telehealth were scant and miserable. I hated it. So I'm an MS neurologist. Although in the past I worked in big healthcare systems where I was required to take general neurology call or stroke call, something that I do not like doing. And the one hospital system I worked in had a telehealth stroke unit. So at night, like once every 8 weeks, I would have to stay up at night, and God forbid when someone maybe had a stroke, I had to get on camera with them in the ER, try to do an exam on camera, figure out if I thought they had a stroke, and then determine whether or not to give them a lytic, like Drano. And I didn't like that very much. It was really stressful and scary. Stroke is not my gig. And that was my only experience with telemedicine. And I didn't like it at all. And if you had asked me to do telehealth, I would have said absolutely not, no thank you. I would have told you I'm a classically trained neurologist and I want to see my patients in clinic, which is still the case actually. But then, as Stewart shared with you, we were getting ready to launch the Boster Center for MS, where I'm presenting to you right now. And we opened up after much to do on March 19th, 2020. And 2 days later, the governor of Ohio saw fit to close the state of Ohio. So here I had a 6,000 square foot clinic with lots of awesome clinic rooms and infusion stuff, and the whole state got closed down. That was not planned for. And I looked at my business manager and he looked at me and we said, I guess we're doing telemedicine. And we didn't know how to do telemedicine. Literally, we started to Google how we do telemedicine. And it was really, truly a hack and slash approach for the first several months, to be honest with you. In reality, it was a complete and total game changer. And what it has done for access to care has really made me a true believer. And I want to kind of walk you through what that experience was like. So first off, there were some emergency laws that were put in place which allowed doctors to do telemedicine. And so because of the COVID emergency laws, doctors are now in the now allowed to see people across state lines. So I'm an Ohio physician, I have an Ohio license. And so under normal circumstances, I couldn't do telehealth in California. But during the COVID pandemic, they liberalized that. Also, in the past, telemedicine was not allowed to ever be done for a new consultative visit. So you couldn't meet someone for the first time on telemedicine. And the government said, oh, go ahead and do that also. They really liberalized things quite a bit. Also, and this is important, they allowed billing to be the same on telemedicine as it is in the office, which made it viable. In the state of Ohio, I'm a medical marijuana recommender, and we were able to do that on telemedicine. And so they really just kind of liberalized things, and it allowed us to do exactly what needed to be done, which was to provide tertiary level neuroimmunologic care to someone with a chronic condition, MS, despite the fact that it wasn't safe to be outside or travel. And that began the journey of telemedicine in the world of MS. Here we are about 18 months later into the pandemic. And where is the new normal? What is the state of affairs? At least I can share that with you as it relates to the Boster Center for MS. Telemedicine is deeply ingrained into my life. Literally between 50% and 75% of all the clinic visits are still being done via telehealth, quite literally. And I have found certain areas where I think it is the bomb.com. It's better than seeing someone in clinic. And I've also found some other areas where it's just like super not okay. So let me share a little bit of that with you. We have found a pattern where there's some wins with telemedicine. For example, if I'm going to see someone as a new consultative visit, I like to do a 2-hour visit when I meet someone because I need a lot of time to get to know you. And traditionally, I would bring you to the clinic and we'd spend a really long time together. But what I found I can do is I can do the first hour on telemedicine. You mail me your MRIs and all of your lab reports and all of your other documentation from all your previous doctors, and I receive it all and I look at everything before I see you. And then we jump on camera and I review everything that I've read about. I take your history. I also go through all your MRIs where I pull them up on my screen and I show you my screen so we can look at them together. And then at the end of that first hour, we game out homework, things that you need to look up and do and things that I need to do. And then the second hour, I ask you to come in the office where I can examine you and we can game out what to do. And by breaking things up, I'm very efficient with our time, but most importantly, I prevent you from having to be exposed in the office. We have also found, for example, that doing routine MRI reviews is a brilliant thing to do on telemedicine. So what I used to do was you get your MRI in the morning and then you come to clinic and then I'd pull it up on the screen and we look at it. Now we do the same thing, except you get your MRI in the morning and then you go home and then you pull it up on the screen, telemedicine, and we go over it. There's a lot of things like that that work really, really well. We have found ways to augment telemedicine. So there's certain things that we want to collect information on that work really, really well across telemedicine. For example, patient-reported outcome measures. I have a fancy pants electronic medical record, and we have created a system where we can send you surveys, questionnaires about depression and anxiety and energy and a host of other things that are really, really important. And you can fill them all out online just before I see you. And when we open up the chart, I can see everything that you did just before the visit, and it informs our discussion. We are starting to use remote cognitive testing where I send you a special code, you log on to a special program, and you do brain teaser tests online. I see the results, and it actually is validated neuropsychometric testing. And so I can do that remotely, which is super cool. We've even started to use some very creative smartphone apps that measure hand function and walking function and cognition. So we're really trying to figure out how to make the most of telemedicine with the goal of keeping people safe and at home and creating access where there wasn't before. So before we transition to where I hope the future leads, I would like to spend a few short minutes and share some pro tips, things that I have discovered help optimize a telemedicine visit, because it's my hope that this is something that is available to you and your family. So a couple pro tips when you're trying to get ready for a telemedicine visit. Number one, make sure that the device you're using is fully charged and plugged in. I can't tell you how many times a phone dies or a computer dies in the middle of a telemedicine visit. So getting that bad boy plugged in and fully charged is the first pro step. The second thing is test out your internet connection. Don't do it for the first time right when you're trying to log on. Check and make sure that your Wi-Fi is solid, and if you need to change where you are or use a different hotspot or what have you, you want to take care of that ahead of time. Number three, you want to set your iPhone or your laptop up on a stand. You don't want to be doing this, because if you're doing this, I'm going to need to test you. I'm going to need to do some things with your hands, and it's going to be really, really challenging. And also it'll bounce around and it makes it really hard to see you. So if you can put your phone on a stand so that your hands are free, that's really helpful. Excuse me. Next, make sure that there's good lighting. And so if you're in a dark living room, I really sometimes can't see you very well. It's all in shadow. And if I'm trying to look at exam findings like on your face, I need it to be really well lit. So consider the lighting so that I can make sure that I can see you. Next, make sure that the area that you're going to do the telemedicine visit in is quiet. I can't tell you how many times I've seen a telemedicine visit start. The patient is sitting in the driver's seat of their parked van. They have 4 children behind them that are quite literally jumping back and forth on the seats. And while the person's trying to have the telemedicine visit, they're trying to very casually smack their children and get them to stop it. And it really interrupts our ability to game out how to live your best life with MS. So make sure that it's as quiet as you can make it. Please have all of your medicine bottles present. So if we need to go over them, we can grab the bottle and look at it really quick. It's a really easy way of verifying medicines. Lastly, or maybe not lastly, but maybe 2 other things. I want you to prepare your questions. Now, MS Views and News on their website has a fantastic downloadable form that you can print out and then fill out, and it will guide you through getting all of your MS questions ready so that when you're on telemedicine, you have it in front of you, and that's a really important tool. The last pro tip is to consider inviting a village member to Zoom in. So you can have your spouse or significant other or your sister, and even someone that lives in a different city, if you give them the Zoom code, they can join camera. And so we can do like a modern version of the Brady Bunch where we have different cameras set up and we have different family members and stakeholders and village members present, and it really can improve what we offer. Now, what's the future? Well, I don't know, but I can tell you what I wish it and hope it will be. I hope that the emergency medical laws that have allowed doctors like myself to provide access to underserved and under-reached areas through telemedicine, I hope those laws persist. I hope that we are able to continue to use telemedicine. I hope that we are able, in fact, to see patients across state lines, and the future looks bright. There is a new licensure in the United States called an intra-state license, where if a doctor has an intra-state license, it's honored in other states that honor that same system. It's not available in Ohio yet, but as soon as it is, I will be applying for it. Again, thank you very much for your attention, and I'll turn this back over to a Q&A. Stewart, if you'd like to join me, we can fire it up with the questions.
That's awesome. Thank you very, very much for stepping in for Dr. Hughes. And please remember, everybody, that after we finish this Q&A, we are going to do the Dr. Boster portion of this entire presentation. Okay. All right. Great. Thank you, doctor, and thank you for all your smiles. So we do have quite a few questions again, of course, because we will always continue to. So using telehealth, though, I know you spoke about it, but I would like you to reiterate about this. How would you diagnose somebody with multiple sclerosis?
So to diagnose MS, there are 5 elements, all right? Most of them can be accomplished across a camera. The first one is your story. We call that the medical history because it sounds fancy. It's the stuff you tell me. And so you can tell me that on a camera the same way that you can tell me that in person. The second thing is a neuro exam where we're looking for findings that support what you tell us. Now, there are some findings that you can absolutely see on camera. So, for example, leg weakness or unsteadiness of gait. Other things are less easy to see, like sensory changes. So some of those you can do on camera, some of them you can't. The third thing in the diagnosis is the MRIs. And those absolutely, as I shared, can be looked at and discussed across a camera. Number 4 is spinal fluid. That's a laboratory that I can review. And number 5 is prove it's nothing else, which we typically do through imaging and labs. So as you see, the vast majority of what we need to accomplish to diagnose MS can in fact be done via telemedicine.
Okay, thank you for that. All right, next.
Keep talking, I'm here.
Oh yeah, you're there. Okay. Like when you were doing like you did with me, the sound.
Yeah.
Can you talk to people about that with that pata and that ta and all that stuff?
Talking about at the beginning of the pandemic, he and I decided to create a video, which is on both of our YouTube channels, sharing how a doctor-patient relationship can be done on camera. And we even took it a deep step further, and I did a full neuro exam on camera. Stewart, if you'll participate, we'll just recapitulate that. So one of the things that the doctor and neurologist wants to do is test the cranial nerves, the nerves that run your face. And oftentimes we do that visually, like we'll look in your mouth and see how your palate elevates, except that's really hard to do on camera. Instead, we can do it by listening. And so for starters, if we want to test the cranial nerve that moves your face, that's called the facial nerve, then we can have someone say the P sound. So Stewart, if you would say pa, pa, pa.
Pa, pa, pa.
And so he's pronouncing the P correctly. I can tell that the muscles that move his mouth to say pa work. Let's do another one. To test the 12th cranial nerve that runs the tongue, then we use a sound that uses the tongue properly. So it's the T sound, where you slap the tongue against your teeth. So say ta, ta, ta.
I will, though, as soon as you promise that I don't have to show you and examine the inside of my mouth, all right?
There, yeah, I promise.
Ta, ta, ta.
Yep. And now to test the 9th and 10th cranial nerves, we can make the K sound, because that moves the back of the throat. So ka, ka, ka.
Ka, ka, ka.
And so by saying pa, 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 ta, 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 ka, 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 I'm able to test Stewart's cranial nerves 7, 9, 10, and 12 just by listening. And that's an example of how we can use telemedicine to our advantage and still learn important stuff.
You want me to say that?
No, you're okay.
That's good. Well, you paused, and I wasn't going to say pa, 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 ta, 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 ka, ka, ka.
You're killing it, man. Luke, sounds great.
Right. You're up. All right, I'm up. Right. I have to ask the next question. I forgot about that. All right. Having obtained a certain degree of NEDA, which I'll let you explain what that is, I want to know how to best sign up for clinical trials for remyelination drugs in the pipeline.
So, excellent question. Let's unpack it a little bit. First, they comment on achieving a clinical target of NEDA, no evidence of disease activity. NEDA is a target for treatment. It's actually my target for treatment. No attacks, no new spots, no change on exam. And what they're sharing is that right now they've achieved that, which is really awesome. The person also shares a desire to participate in clinical trials. So I want to start by saying thank you, because if people like you were not willing to participate in clinical trials, we would have no drugs to offer folks. So it's only by virtue of people impacted by MS that volunteer to participate that we can find new therapies, like remyelination therapies. And so what I would recommend that you do is you look on clinicalgov.org, or you look on the National MS Society, and you look for clinical trials in MS remyelination in your area. Calling the National MS Society is a great way to do that. And then you can hook up with a place that's doing that kind of stuff. Thank you again for your interest in that research.
Great, thank you. All right, next, I'm going to go through different research and trial questions that are all together, so that way it'll make it a little bit easier. Are there any trials for MS folks over 60 who are living with MS or living well with MS?
So most phase 3 pharma trials that are studying a new drug against an old drug cap at 55, which is not appropriate nor fair. Now, there are statistical reasons why they do that, but unfortunately, most of those phase 3 trials where we're developing new drugs do not look at patients that are older. There are some individual clinical trials run by particular investigators doing that, but this is another area where I wish that we would be able to move forward, because people don't stop having MS at 55.
That's true, thank you. Going further about clinical trials, so what do you have, or what is there specifically for Black Americans and for trials specifically for other people of color?
So I'll start by saying anyone impacted by MS who qualifies for a trial independent of their ethnicity. And so a clinical trial opportunity for a Caucasian is the same clinical trial opportunity for any other ethnic group. And that was really what I was speaking about earlier, about we need to do a better job of making sure that all communities are aware of what's available and that all communities are invited to be included in that experience. Now, there are some specific investigations. There's some great work done by Oxenberg and colleagues, UCSF and other places around the country, looking at the genomics and genetics of people impacted by MS in certain ethnic groups. And that's very exciting research, which is works in progress.
Great, thank you for that. Are there any numbers on American Indians affected by MS?
I do not know the answer.
Okay, but could you tell then, for people living in like Southwest USA that are living on the tribes that are in that area, is there any place specific where they can go to within their community for MS treatment?
So I have to admit ignorance. Now, mind you, I'm a guy that lives in Midwestern United States, and I've never been out west, so I don't actually know. One of the tools I would recommend is to reach out to the local National MS Society or the local MSAA or MS Foundation chapter and ask them who the providers in that area are. They will invariably be able to point you laser focused to who those folks are.
Sure, thank you for that. So for everybody to know, and if whoever might be of American Indian descent, this is something that MS Views and News will be looking into in 2022. is how to provide programs to American Indian communities in various portions of the USA. We are in touch already with the American Tribal Council, which is out of Washington, D.C. So
That's
we're
awesome.
hoping to be able to tap into that corridor of the USA for next year.
That's awesome.
Okay, thank you. Next, what is the latest on remyelination to repair old damage, as well as what there's going to be to available? Well, I'll let you talk about this first.
So conceptually, remyelination is a bit of a holy grail. When you think about MS pathology, and I'll use this wire in front of me as an example, what's happening in part is that the plastic coating, which insulates the wire, is stripped off. All right, so we're talking about a nerve, and the plastic coating is actually a fatty substance called myelin, and it's being stripped away. And so you're exposing a bare naked wire, which can break. And that's one of the major aspects of pathology in MS. So what would be super awesome is if we could give you a medicine that put the plastic coating back on the wire, that remyelinated. And it turns out that's super hard to do. Now, there are active ongoing investigations right now. This is a very, very hot topic. And I wish that this question had been asked to me next week, because this week, the International ECTRIMS Congress is going on, where all that information is being updated and presented. And I have not had time yet to absorb and integrate it all. And so I will be very, very excited to answer that question in the near term after we have a download of all that awesome information from ECTRIMS.
Okay, thank you. How are upcoming meds and trials different from the current drugs available?
So I'll use a specific example. I'm very involved right now in studying a type of drug called a BTK inhibitor, butyrate tyrosine kinase inhibitor. So these BTK inhibitors are small molecules, they're pills, and they've been approved and used in various types of cancers. It turns out that they're amazing, it looks like, in treating MS. And we've done a phase 1 and a phase 2 trial, and now we're participating in phase 3 trials studying these BTK inhibitors in people impacted by MS. Now here at the Boster Center, we're studying this in folks with relapsing MS. We're studying it in folks with primary progressive MS. We're getting ready to study it in folks with secondary progressive MS. And why am I so excited about these molecules? Exactly what you said, they're different. One thing that BTK inhibitors do is they block B cell communication without murdering B cells. And that's a pretty cool trick. Some of the more effective MS medicines currently on the market work by murdering B cells, which is a highly effective way of treating MS. But these BTK inhibitors, what they do is it's like, la, 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 I can't hear you. And it blocks the signal without murder. And that's a good thing because it decreases risk of infection. Secondly, these BTK inhibitors work on a cell in the brain that we've never been able to reach before, part of the innate immune response called microglia. And being able to turn off naughty activated microglia is a really big deal. So my point in using this as an example is as we bring new drugs to market, we're really bringing new techniques and new mechanisms of action to beat the hey out of MS.
Right, thank you. A person is asking, I want to participate in clinical trials. If the trial is for new DMT, will I have to stop taking the DMT I'm currently taking? I'm taking Gilenya, and I heard that stopping Gilenya is problematic. Please speak about this.
Very excellent question. I'm going to answer it in a reverse order. So Gilenya is an excellent medicine for MS. It's a pill that you take once a day. And we've discovered that if you're taking Gilenya and then you suddenly stop cold turkey and do nothing else, there's a rare risk of rebound MS, where your MS comes back with a vengeance and you actually have a very, very severe attack. Now, it's not common that that happens, but it's also mitigatable. There's a way out. And so I'll share with you, for example, what I do. I stop Gilenya, and then a month later, I give you one slug of steroids, and a month later, another slug of steroids. And what that does is it eases the cells back into the bloodstream instead of them bum rushing and creating a ruckus. My point here is you can get off Gilenya, you just have to be planful. Now, the second part, which was actually the first part of the question, was if I'm on a DMT, will I have to come off to participate in research? And the answer is yes, you most likely will. And in fact, it's a bit more complicated because we don't want to start an investigational drug until the Gilenya is completely washed out of your system. And so there's typically washout periods. You may need to be off Gilenya for 6 months, for example, before you're eligible. And you can discuss those specifics with the clinical trials team for sure.
Right. Thank you for that. All right. So we're now finished talking about the clinical trials. Next, we're going to talk about medications. So for everybody out there that's got questions about medications, now it's time to use your fingers, exercise them, and start typing your questions. So first one is from, I'm going to say names intermittently, okay? You're not the only one with your first name, okay? There are many people online with your same first name. And unless it's really, really strange, like Aloysius Diddlehopper, don't worry about it. There are plenty of Marlas out there. Oops, I said Marla. Okay. Will the BTK help with spasticity?
We don't know until we study it, but that's not my expectation. So I would expect a BTK inhibitor to help slow MS, decrease risk of attack, slow progression, slow brain volume loss. If it turns out to help with spasticity, that's something that we're going to discover through the course of the clinical trial. I would imagine, Marla, that we would treat the disease with a disease-modifying therapy, and then at the same time treat spasticity with whatever tools we needed. Stretching, physical therapy, as Gretchen eloquently described to us, oral baclofen, baclofen pumps, Botox, all that kind of stuff to optimize spasticity.
Okay, thank you for that. Now, let's talk about spasticity a little bit more. Some people are confused between the word spasticity or leg cramps or contractions or blah, blah, blah. Can you differentiate, please, on those different options, or are they all actually the same?
So they're all different, and sometimes there's a situation where there's a medical term which has a very specific medical definition, and sometimes that term may be used loosely in common parlance, but it doesn't really have the same meaning, and that's confusing. So let's talk through it a little bit. So when you're dealing with a limb, all right, we're thinking about several aspects of the limb. One of them is the way it feels, that sensation, and has nothing to do with your question. Another one is strength. All right. So how strong is the limb? How strong is your grip? How much can you lift? For how long can you lift? And there's strength. Separate from that is something called tone, which is the resistance to passive movement in your arm. And it's really, the tone is really what we're dealing with when we talk about spasticity. Allow me to explain. When I want to bring this coffee cup to my face, I have to do two things. This bicep muscle has to shorten, and meanwhile, the tricep muscle has to relax, because if it doesn't relax, I can't bend my arm. Now, I don't tell my tricep to relax. I just say, coffee, and I bring it there. My brain turns the tricep off for me. In the setting of MS, when there's damage to the brain and spinal cord, affecting the parts of the brain that control tone, the tricep might not get the memo. So when I'm trying to do this, my tricep doesn't know to relax. It's trying to do that, and the result is a tug-of-war across my arm. That is called spasticity, and that presents in three ways. Spasms, which is where a limb bounces. A cramp, which is a visible contraction of a muscle belly, which is typically very painful. And lastly, a limb that's hard to bend. Now, the last term that you brought up, Stewart, contracture, is different. It's where the tendon has been kept in a shortened position. Like if I kept my arm like this for like 5 months, this tendon would shrink and then my arm wouldn't move past it. Kind of like on a door jamb when you have a door stop and it only opens a certain amount. And that has nothing to do with spasticity. That has to do with contracture of the tendon. Excellent question. Thank you.
Got it. Thank you. So next we have concerning the medications, more so. A subject that a lot of people have no knowledge about, but they ask all the time, and that is LDN or low-dose naltrexone. What can you tell us about this and why it is used?
Yep. Low-dose naltrexone has very, very scant data for its use in MS. There's not a lot of information supporting its use. Despite that, many patients ask me about it. And I always joke that whoever did the marketing for LDN, I want to hire them, because it's interesting that in the absence of data, so many people ask me. Low-dose naltrexone, what is it? First of all, the drug naltrexone is a drug to block opiates. And so it's used for addiction medicine. It's a completely different thing outside MS. Low dose naltrexone is when you take a super small dose of it, typically about 4.5 milligrams. And there is some belief that low dose naltrexone can help with some MS symptoms. Now, I'm of the opinion that low dose naltrexone is not dangerous. It's also not very expensive to have it made. And as long as you're doing it in addition to something that I know works, groovy. What would make me sad is if you said, I'm going to take LDN instead of something that we know works. And so I have some patients that take LDN and they've noticed that, for example, one gentleman feels like he can button his shirt a little bit easier. And so he continues to take it. And I think that's great. And so I always tell people, if you take LDN and it helps you, make sure to tell me so that I can learn more.
Great, thank you for that. All right, let's talk about SPMS, medications, and also another person, we're going to tie in some of these questions. Is Kesimpta used on secondary progressive MS, or if not, what is it used for? But again, going back, what is used for secondary progressive?
So this is a super hot topic. Remember I mentioned that there was the ECTRIMS meeting. A colleague of mine, Dr. Dunn, and I presented on SPMS to a group of people, kind of a review. And so this is very top of mind for me right now. Great question. People with MS who have an attack have a relapsing form of multiple sclerosis, period, right? So if you have MS and you've had an attack, then you have a relapsing form of MS. And at some parts or time periods during your disease, you may have more frequent attacks and you're less likely to progress in your disability, although you can. At other points in your MS, typically later in your MS, you may have attacks less often and you're more likely to have progression. You still have a relapsing form of MS. You are still at risk of having attacks. You are more at risk of having progression. And some clinicians call that phase, if you will, secondary progressive MS. I actually find the term to be near useless, Stuart. I don't find it to be very helpful. Here's why. The medicines for relapsing MS decrease relapses and slow progression. So I don't care where you are in your journey of MS, whether you're having lots of attacks or lots of progression, I want you to be on one of those medicines. So having relapsing MS or secondary progressive MS doesn't change that very much. There is a misconception, in my opinion, that SPMS is like stage 4 of cancer, God forbid, or something like, dun, 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 now there's no options, which is BS. If you look at the American labels for most of the MS medicines, they've updated them to include relapsing forms of MS. So Kesimpta, Mavenclad, Gilenya. I mean, I could list all these different MS medicines, and they're approved for relapsing forms of MS, which is clinically isolated syndrome, relapsing MS, and so-called secondary progressive MS. And right now, if you really look at the information, there's plenty of things that we can use to treat so-called SPMS, because those patients have relapsing disease and they respond to those medicines. In case you didn't pick up on this, it's a very contentious point for me. And it drives me bonkers when a naughty neurologist will say, well, you're in a progressive phase, so we should just stop treating you, which drives me nuts. But thank you for asking the question.
Great, thank you for that. I have to back up on telemedicine for a minute. There are people that are watching that are in the United Kingdom, Canada, and the Philippines, and they want to know if they could do telemedicine with a doctor like you from afar.
Yes, ostensibly. And in fact, at the Boster Center for MS, we do international consults. The process is the same. You submit all your stuff. You got to fly me over your CDs and all your paperwork. It's got to be in English so I can read it. And then we jump on a Zoom call. And I will share that I probably can't do the extent of long-term care if you live in another country unless you're going to fly and see me once or twice a year. But what I have done during this pandemic, Stuart, is a lot of one-time or one-off consultations where a family in the UK or in the Philippines I meet with, and we game out how to optimize things, and then they take that information back to their neurologist. And I have to share with you, that's been a kind of fun experience.
Thank you for that. All right, next, FES. I have no idea what it is, so I'm going to learn from you on this as well. How effective is FES, a person writes?
Stuart, I've been stumped. I do not know what that abbreviation means. As a point, whenever you're writing a question and there's an abbreviation, write out the whole words, because I don't know what FES stands for. But let's move on to a different question.
Exactly. I'm wondering if it has anything to do with electrical stimulation. Okay, great. All right, next. I would like some clarity on the timing of Ocrevus and planned surgeries, including dental. Can I be using, or can I get an infusion around that time?
So this is a question for your neurologist, because your neurologist and you will be able to figure out what the right answer is for you. Speaking in generalities, I do not like to do elective infusions right after a surgery or a procedure. And so, for example, let's pretend a patient of mine had to have a dental surgery. I would want them to have the surgery, and then I would want the dentist to clear them to have the procedure. So we would wait until they were healed before we would do the infusion, because I don't need to rush it, and I don't want to risk an infusion impairing wound healing, for example. And so we would game that out with the surgeon and come up with the right timing. And when the surgeon said, okay, go ahead, then we would move forward.
Okay, great. Thank you for that. We have 8 minutes left in this section of the talk before we begin the Boster section of the talk, okay? All right, so first one is, and I don't know how to say this correctly, I don't think so. Can you tell us about, I lost the question. Hold on one second. Okay, here we go. What is your view for the trial on Simvastatin? Simvastatin.
So I'm guessing that the person's asking about Simvastatin, which is the generic name for Zocor, which is a cholesterol medicine. And Simvastatin has a really interesting history in MS. When I was in training as a resident, there was a paper that came out where we gave Simvastatin to mice with a model of MS called the EAE model of MS. And we damn near cured mouse MS. The EAE model got better with Simvastatin. And so I took the paper and I rushed to my MS attending and I said, look, can we start giving people with MS high-dose Simvastatin? And he looked at the paper and very calmly said, well, Aaron, maybe we should wait until it's tested in humans. Okay, wise guy. It's a good idea. So we tested this in humans a couple years later and found that in some cases it made things worse. Dun, dun, dun. That's a big deal. Now, subsequent to that, there's been more studies and it's back on the table. It's something that we're talking about. And I think that for a lot of patients, it's actually very appropriate. I'm glad that we're studying it again. If you think about this, brain health is a key element to being successful with MS. If you have hardening of the arteries because of high cholesterol, you're going to get worse in your neurological disability. We've actually studied that. And so treating cholesterol actually helps with brain health, allowing your brain to age naturally and not at an accelerated rate. Moreover, there are some anti-inflammatory properties of Simvastatin which are trying to be fleshed out. So more to come, but it is actually an exciting drug that we've been trying to figure out for many, many years in MS.
Great, thank you. So I wasn't that far off with the FES. Several people have written in functional electrical stimulation. So I had two of the words. Do you know anything about it?
So I think functional electrical stimulation is a tool which may help some patients. This is not something you're going to do on your own. You're going to do it with an expert neuro-PT, someone who has experience like Gretchen, and it may assist in your journey of physical therapy. So do I think it has a role? Yeah, I think that it's one tool amongst many that can help us up our game. And so it's something that I would have in my toolkit.
Okay, thank you. I'm going to ask one more question about the line of medication, and then I have some resource questions to ask you, and then we'll end this section of our journey and get into the next. Okay, so what is the recommended interval between the COVID boosters and the shingles vaccine?
So it's not known. We haven't studied that, and so we don't have a good sense. We do know that giving COVID vaccine and flu vaccine can be done together, but I don't know that the research has been adequately fleshed out with varicella yet.
So what would you suggest that a person wait before getting the shingles vaccine after having either flu or COVID vaccines?
It would, honestly, Stuart, it would really depend on that individual, their response to vaccines, if they had ever mounted a response to varicella in the past. There's a bunch of variables, and so I would need to game it out for that individual human. That stated, we would want to ideally do the timing so that we weren't overlapping, and I think that is doable. Oftentimes, for example, a patient taking ocrelizumab, let's say, where there's an every 6-month infusion, we may give a varicella vaccine, the first Shingrix, a month before one infusion, then 6 months later, a month before the next. So with information like that, we would then have to just time in when do we put in the COVID shot.
Okay, thank you for that. All right, going on to resources. I live in a rural community, and although I am aware of several people in my area, MS is not a priority of the healthcare system, and I cannot say that the medical staff are well enough trained or educated about MS. The community does not have a practicing neurologist. How does one find somebody, and how would one get to somebody if living on the outskirts of society?
Yeah, so there's a couple ways to do this. Now, mind you, I'm biased, right? So I'm a MS subspecialist. I'm not a general neurologist, and I just want to be clear about my own biases. I think that there's an option, for example, of traveling to an MS specialist once or twice a year to make sure that you're getting the proper once over, all the proper MRIs and the proper functional testing, and that they're doing the proper exams, and that they're optimizing your disease modifying therapy, and they're optimizing your symptomatic management, and then they can send you home. And I do that a lot with folks that don't have an MS neurologist in their community. They may see a general neurologist and I co-manage, or they may just see their primary care doctor and I co-manage. Now, telemedicine, as you can imagine, has made that better, because if you can come and see me once or twice a year, I can game out everything else on telemedicine. And so I think more than ever before, that is a very viable option, something that does work for folks. Another thing that real quick, sorry, is just upping your game and making yourself your own advocate. So jump onto the MS Views and News website and check out their myriad lectures from experts around the world in MS, and then you can up your game and you can educate yourself and make yourself the best self-advocate possible when you talk with your local providers.
Thank you for that. You paused, so I thought I should go on.
Sorry, yeah.
Okay, all right. The last question concerns MS groups. So a lot of people stating that they're, in different areas of the country, they don't have enough of the groups in their area, or, and how to find them. And before I let you speak about that, I'm just going to make mention, though, that these days, just about everything is on virtually. So even if there's no group in your specific area, in, for instance, Milwaukee, Wisconsin, you can tune in to a group in Miami, Florida, okay? Or, for who are doing this, or whoever else might be doing virtual programs. And they don't have it just for the MS patient. They also have caregiver groups that are out there as well that are virtually based. So realistically, you could be on the moon, okay, and tap into something going on in, I don't know, Sturgis, South Dakota, okay, except for snow. Now I'll let you speak.
So just to piggyback off what you're saying, there's never been a better access to support groups virtually than ever before. There are fantastic support groups that are on Facebook, for example. I'll plug friends of mine, My MS Teams, a very, very large support system, which is international. Shift MS. I mean, there's a bunch of really great groups out there. And I think what you'll find is you jump online, you're going to be joined by 100 other people who can't sleep that are up interacting and supporting one another. And so I would look virtually. 100% agree with you, Stuart.
Great. Thank you for that. All right. Thank you very much. You all have a great day. I'm out of here.